You're listening to Just Medicine, an equity in healthcare podcast created by medical students in British Columbia.
Welcome back to Just Medicine. My name is Zoe, and I am a second-year medical student at the University of British Columbia. I will be your host today. I am very excited to announce our guest, Dr. Elise Jackson, and I will give a short bio before we head into our conversation for today. Dr. Jackson recently graduated from the General Internal Medicine Fellowship at the University of British Columbia, where she spent her 5th year completing an Addiction Medicine Fellowship through the BC Centre on Substance Use. She is now working as a general internist and addiction medicine physician in Campbell River and is particularly interested in serving populations that have been systemically marginalized. In her spare time, you can find Elise hiking, camping, kayaking, or otherwise enjoying the beautiful Pacific Northwest. Thank you so much, Dr. Jackson, for joining us today. My name is Zoe, and I am the host of the Just Medicine podcast today. I'm super excited to discuss a little bit more with you about physician burnout and addictions medicine. So welcome.
Thanks so much. I'm happy to be here.
Yeah, so I think just to start off, really broad, would you mind just introducing yourself and telling us a little bit about who you are and the path that you took to get where you are today?
Absolutely. So I'm Elise Jackson. I am currently a 5th year general internal medicine fellow, and using my 5th year of the GIM fellowship to do an addictions fellowship. So we're lucky at UBC in that the 5th year of GIM is very open and very flexible and really designed for us to tailor to our own learning needs and interests. So I've been able to fit the 1-year addictions fellowship into my 5th year of internal medicine. And so I am 3 months from the end of that and 3 months from graduating from residency and fellowship overall, which is very exciting. In terms of my background and kind of how I got here, I'm not from BC originally. I did most of my training actually out more east of here. I went to undergrad at McGill and then med school at U of T at University of Toronto, and then came out to UBC for residency. And so I did my core 3 years of internal medicine residency, and then the last 2 years have been my general internal medicine fellowship, with, as I said, this year being the addictions fellowship kind of focus.
Yeah, that's great. I would love to know a little bit more about what sort of a typical day in your life right now as a addictions fellow looks like.
Yeah, it varies a lot month to month, for sure. As you probably know, all of residency is based essentially on 4-week blocks. And so what we do changes essentially every 4 weeks. As an addiction fellow, we have rotations in a variety of settings. So several blocks of inpatient addiction medicine consult service. We have a month of doing a rapid access addiction clinic. We have a month on the perinatal addictions unit, a month in a treatment center, a month in a concurrent disorders center, a month in detox, and several others that I'm forgetting, but certainly varies a lot. And we get a really broad range of experiences, which is really valuable. And so day to day sort of varies depending on which of those settings I'm in, really. Outside of the addictions fellowship, similarly, GIM and internal medicine look kind of similar in the structure, where everything's based on 4-week blocks. But in that, I was doing predominantly internal medicine and then internal medicine subspecialties as well as ICU.
Do you have any specific interests even within addiction medicine, or are you just interested generally?
Interested generally in addictions for sure. I don't know if within that I have really a specific area of interest. Um, I guess one thing that I am interested in is delivery of addiction services in smaller communities and more rural centers. I'm going to be moving to Campbell River come this fall and have accepted a job doing internal medicine and addictions in Campbell River. And I think nowhere certainly has addictions medicine and addiction services figured out, but certainly larger centers have a lot more in terms of resources and programs available. And so I'm really interested in exploring and expanding the services available in more rural communities.
Yeah, that makes a lot of sense, and I do think that that's something I'd love to discuss today a bit, how those rural communities are equipped to deal with addictions and how the rising rates of opioid overdoses are how that's being dealt with, especially when there's so little resources, as we know, in northern BC and northern Canada as well. Can I ask you, just out of interest for everyone, when you go into an addictions fellowship, is there anything specific that you need to do as an internal medicine resident to go into that pathway? How do you get there from just a general internal medicine?
Great question. I wouldn't say there's anything really particularly specific that you need to do. I think it's beneficial to have done at least one, maybe two blocks of electives in addiction medicine during your core internal medicine training, both because I think it's important to have some experience to know for sure that that's what you want to do. But you do also need, I believe it's 2 reference letters from addictions physicians to apply to the program. And so need to have had some addictions experience in order to have done that. Beyond that, there's not really anything specific. There's no specific requirements in terms of research experience or clinical experiences or anything like that. One of the benefits of doing the addictions program through internal medicine or through GIM is that you have your 5th year already funded. So you have funding available to you. So you're actually not competing with residents from other specialties like family medicine who are doing an extra year of training where you're competing for kind of a limited pool of funding. So it's nice to come with your own funding. It makes you a very enticing candidate.
Right. Yeah, that makes a lot of sense. Okay, thank you so much. I feel like that was a great sort of introduction to what you are doing as an addictions fellow. And I think now we can transfer into some more questions about what that really entails and sort of the intricacies of the position. So, first of all, I think one of the really hot topics right now is harm reduction, and especially in BC, Vancouver even is very kind of at the forefront of those harm reduction strategies and have been for a long time. As someone who is working in addictions, can you speak to the harm reduction strategies that you see used regularly in the hospital for people who use drugs, and that helps us meet them where they're at and help them get the best care possible?
So definitely, I am a huge proponent of harm reduction. I think it is really essential and central to our response to the toxic drug crisis. I think it often gets pitted against treatment, which I think is a bit of a false dichotomy. I think treatment and harm reduction both have a very important and essential role to play in treating addictions. I think treatment is essential for people who are ready to make that step, who are ready to address their substance use disorders. And at that point, treatment is absolutely the best thing for people, whether that's an inpatient treatment center, whether that's being on pharmacotherapy like opioid agonist therapy. But I think we also need to recognize that there are some people who, for whatever reason, are not at a point where they're ready to address their substance use, or they're trying to address their substance use, but understandably struggling with it. It's not an easy thing to address, or they're in the process of getting onto a medication and it's not yet at an adequate dose, and so may still be using drugs for any of those reasons and many more. And I think that continuing to use drugs for whatever reason should not have to be a death sentence for people, that those people absolutely deserve to still receive care and to be kept alive. I also think if people don't have the chance to survive, they're never going to get to a point where they're ready for treatment either. So I think, as physicians, one of our core roles is helping people survive, keeping people alive. And I think that harm reduction is very consistent with that. I think the big kind of tenets or components of harm reduction are uh, sort of overdose prevention. And so that can take the form of overdose prevention sites or supervised consumption sites where people have people have a safe space to use their drugs, supervised by either medical professionals or by peer workers, where there are resources to be able to respond to an overdose or an adverse reaction. I think one of the big limitations that we're seeing now with overdose prevention sites is that as the population of people using drugs shifts more away from injecting towards smoking, that most of the overdose prevention and supervised consumption sites were set up primarily for injection. And because of the way they're set up and because of things like fire codes, people aren't typically able to smoke. And I think that we're getting to a place where that means that a lot of people are excluded from those sites. So I think that's something that we need to revisit sooner rather than later. Other aspects of harm reduction and overdose prevention, things like naloxone kits are essential. The other thing that I think is part of harm reduction is preventing adverse events that come from substance use. And so often this includes infections. So things like providing safe injection supplies and safe smoking supplies. Certainly, bloodborne infections are more commonly transmitted with injecting, but I think many people, including patients and providers, don't know that they can also be transmitted via smoking, certainly less commonly, but still can. And so ensuring people have safe supplies to be able to use. I think I would consider this part of harm reduction is the move towards decriminalization in BC, with the decriminalization of small amounts of drugs for personal consumption. One of the more kind of final stages of harm reduction is safe supply. And that I think is probably the part of harm reduction that where there's the most controversy, both in the public and even within the community of addictions providers, is should we be providing people with a safe supply? If so, what should that look like? Should that be a medical model? Should it be entirely divorced from the medical system and administered by, people who use drugs? So I think that is certainly an area of controversy where people have very diverging opinions, and I am interested to see where things go with that over the next few years.
Mm-hmm. Yeah, it's interesting. I was actually going to ask anyways, how have the rules and how is the climate, surrounding the possession of drugs, especially around or within the hospital? Like how has that changed since that law was passed with the decriminalization of small amounts?
I think it's quite dependent on where you are. The Vancouver Police Department had been essentially operating under an understanding that they would not criminalize people with small amounts of drugs for many years, although it wasn't official policy or law. That was essentially, to my understanding, how they, for the most part, had been operating. So I think within larger centers like Vancouver, it may not have made as much of a difference. In smaller communities, I imagine it probably has made more of a difference and has made, people feel more safe, more able to use their substances without fear of criminalization, more able to use in public spaces, more able to access overdose prevention sites. In terms of how it has affected hospital use, that still remains, I believe, sort of a health authority or an individual hospital's jurisdiction. And there's actually been some interesting discussion recently, just in the last few days, even where some articles have come out that certain hospitals had sent out memos to their staff saying that they should not stop patients from using substances in their rooms. And there was some backlash against that because of concerns about employee safety. But I think we're in this tough position where, obviously we want to ensure a safe work environment for everyone, and people shouldn't be exposed to harmful substances at work. We also recognize that access to substances and withdrawal is a big barrier for people staying engaged in care and being able to receive appropriate treatment. And so how do we reconcile those of keeping people comfortable, allowing them to continue using if that's what they want to do, but providing a safe environment, not only for staff, but for other patients as well.
Yeah, and I actually know another question. When you say using drugs in the hospital, does that mean genuinely doing the same sort of protocol as a patient may do outside the hospital? Or I've heard definitely that there's a bit of a spectrum to it, and sometimes physicians will, or a lot of times, especially addiction specialists, will provide substitute opioid therapy to sort of help with those withdrawal symptoms. Can you talk a little bit about how that works and what the protocol is surrounding that?
Definitely. So that's a huge role that addiction medicine physicians have within the hospital, is managing withdrawal and, um, getting people on some kind of replacement or agonist therapy.
Mhm.
Like, from a physician perspective, certainly the goal in an ideal world would be to get everyone onto some form of evidence-based opioid agonist treatment. And so by that, I mean things like methadone, Suboxone, Cadian as being sort of the core set of medications that we use that have strong evidence for overdose protection, strong evidence for retention in treatment. And so from my perspective, ideally, I would love to get everyone with an opioid use disorder onto one of those medications in hospital. That said, not all people want to stop using. Um, and so for those people, we often rely more on providing as needed short acting medications. So things like hydromorphone, sometimes even fentanyl in the hospital, not with the goal of getting them onto treatment if that's not what their goal is, but
Mhm.
more as sort of a way to keep them comfortable and allow them to remain in hospital for the course of their treatment. We also often use adjunctive short-acting medications like hydromorphone for patients who we are starting on some form of medication like methadone or Cadian, because of the fact that you have to titrate it slowly over a number of days to weeks to months.
Mhm.
And so we want to give people something to temporize in the meantime.
Right.
That said, I mean, there are people who may either decline the substitutions that we are offering them, or, you know, as the toxic drug crisis has progressed, people's tolerance is just going up and up and up, and we're often, to be honest, not able to meet their opioid requirements. And so in those cases, people may be choosing to supplement with their own supply of unregulated substances.
Mm. And sort of related to this, a big topic, especially for incoming medical students who may be listening to this, there is a lot of cases, I've heard at least, that unfortunately, because of this need that some patients have, that they want to be able to access their own supply, they end up leaving, which may be against medical advice. And can you touch a little bit on sort of the implications of that for patient care, how that works, how it's allowed, what doctors do to mitigate it?
For sure. I think the most important element when a patient with a substance use disorder or not, wants to leave against medical advice is making sure that they are competent to make that decision, and so that they understand and are able to articulate the risks of leaving and how that applies to their specific situation. So that is step number one, regardless of who the patient is.
Mhm.
If it is a patient with a substance use disorder, or any patient, again, really, I think getting to the bottom of why it is they want to leave, often for our patients with substance use disorders, that is because of inadequately managed withdrawal. But it also might be things like trauma associated with the healthcare system, feeling, judged or marginalized by other patients or by providers. And so getting to the bottom of why it is they want to leave. If it is because of wanting to use substances and withdrawal, certainly we would try and do things like offer them more medications, offer to go up on their as needed medications, if possible, titrate their medications faster, obviously within what is safe, um, and see if we can address things that way. Another option is to, allow patients to leave the hospital, go and use outside the hospital and come back, and encourage them to, even if they do want to continue using, that they are still welcome to be admitted to hospital. they shouldn't use in their room, but if they want to go outside and use, they can come back in. Some hospitals like St. Paul's actually have an overdose prevention site on site, like within the hospital. And so I find that's really valuable because patients don't even then have to leave the hospital and be able to continue using. If you really can't convince people to stay, and sometimes you can't, I think it's just really essential to make sure that patients know that they're welcome back anytime, and that regardless of whether they leave, that you will care for them with compassion if they would choose to return, and then try and essentially set them up for success as much as possible as an outpatient. And so provide them with resources, provide them with a naloxone kit with safe injection or safe smoking supplies. Um, and if they are on some kind of medication, providing them with a prescription to bridge them to whenever they're able to see their provider or connect with a provider. But it's tough. It's always tough when a patient decides to leave. Yeah.
Mm-hmm. Yeah, and so I also think, I've heard from other addictions medicines docs that, hospitalization can sometimes be a really great time to initiate or kind of coordinate some sort of care and sort of like a touch point. And I think that's really interesting. And I'd like to, hear more how you use as someone who's in this field when you see a patient, how you can use that hospitalization or point of care to really make a difference.
Yeah, definitely. I think hospitalization is a really valuable time to engage patients with substance use disorders, because often, these are people who have very challenging life circumstances. They may not have housing, they may not have a regular care provider, they may not have a lot of interaction with the healthcare system. And so being able to sort of take advantage of whatever opportunity you have to engage them is really important. I also often find that people, when they are in hospital, are at that point more motivated to make a change, particularly if the reason for their admission is related to their substance use, whether that's an overdose, an infectious complication, an episode of psychosis from stimulant use, and that, we can use our motivational interviewing and clinical um, and rapport with the patient to be able to highlight kind of how that might be related to their substance use, and that can often be a motivator for patients to make a change. I think the other benefit of being in hospital is that you have an interdisciplinary team built right in there, and so you can not only as the physician prescribe medication that may be needed, but then also get them connected to social work to help with housing, to help with disability or income assistance applications. You can ideally get them connected to a primary care provider or someone to continue providing their medication on an outpatient basis. A lot of the hospitals have peer workers who are so phenomenal, and are really helpful in engaging patients and making them feel welcome and feel less alone. And so I think just having that inbuilt team to address their addiction from multiple angles is really, really helpful.
Mhm.
I think the other benefit of being in hospital and being in a monitored setting is that we can often titrate medications a lot more rapidly or a lot more frequently than we can as an outpatient, because as an outpatient, you have to come in, you have to get reassessed before we can make a change to your medication. Whereas in hospital, you're being constantly monitored. Depending on the medication, we can go up a lot faster. I think that's particularly true for methadone and Cadian, where the titration process as an outpatient can take a really, really long time. And we're definitely able to get people up to a lot more therapeutic doses a lot quicker and provide adjunctive medications like hydromorphone or Tylenol or clonidine or whatever they may need um, in the meantime as well. That said, you certainly see patients who are not ready to make changes to their substance use. And sometimes that's because they're just too overwhelmed with pain or illness or coping with whatever has brought them in. And so respecting, obviously, that that's their decision to make and supporting them in whatever other way you can. But I will say, I find that a lot of people, hospitalization can sometimes be a bit of an eye-opening experience and help them realize or make them realize or kind of clarify how their substance use is impacting their life and their health.
It's definitely a huge experience to be hospitalized, and I do think that, it's really positive, all the effects that, all these different team members can make on one patient's life. I am curious from your experiences working in more rural communities, how does that look different in a rural community compared to a huge, like, urban center like St. Paul's where it's all set up?
Yeah, I haven't had a ton of experience in smaller communities in the addiction field so far, but certainly from when I have done rotations at smaller hospitals, a lot of these addiction medicine consult teams are not, just don't have the same resources that we do in Vancouver, for example. A lot of them are doing a phenomenal job with a lot fewer resources, but may not be able to have all of the interdisciplinary team members that we do, somewhere like St. Paul's Hospital, where we have, you know, not only social workers and nurses, but also like a dedicated addiction pharmacist and things like that. Um, so definitely more challenging. Also, the availability of different medications to treat substance use disorders varies in different communities as well. So, depending on where you are, the pharmacy that your patient is going to may not have Cadian, for example, and so you're limited to just methadone or Suboxone or some of the kind of newer strategies that we're using, like fentanyl patches or buccal fentanyl, may not be an option in those communities, and so your toolkit for treating things is just more limited. I think too, it also, there's also, depending on the community, big variations in public and political support for harm reduction, for substance use treatment and things like that. And so that also for sure can be another barrier.
Thank you so much for sharing, just sort of your perspective. I think it's really helpful to have as well a little bit of knowledge about what's going on, outside of just Vancouver. So I think I want to just move into a few more questions, a bit more about how working with people who use drugs and this sort of difficult situation where you're constantly trying your best to mitigate harm reduction while also helping with treatment, as you said, how that might affect us as healthcare providers. From your perspective, how has working in populations with high rates of, for example, opiate overdoses, poor social determinants of health, as you mentioned, how has that affected physician burnout around you?
Hugely, to be honest. It's medicine overall is not an easy profession and can be really taxing and really emotional. And I find that that is heightened even more so within the addictions field. I definitely have found it really draining and quite challenging doing full-time addictions work this year. I love it and I find it really important and really meaningful and really fulfilling, but it is still very challenging. I think some of the things that are sort of more unique to addictions medicine is, we just see an incredibly high rate of mortality in our patients that is disproportionate to their age. Um, Many of these people, who have substance use disorders are dying in their 30s, 40s, even younger in their teens and 20s. And, I think as a society, we are more comfortable with death when it is someone who's lived 80, 90 plus years, and just seeing this incredibly high death rate in people who are young, who are otherwise often really healthy, is really challenging. And you build a rapport with patients, you build a relationship with them, and having patients die frequently is really challenging. I also find that it's tough as a physician when I don't feel like I have the tools to help a patient. And often that's because the root of their use disorder, or a big, even if it's not the root, a big contributor to their use is unstable housing, intergenerational trauma, abuse, all of these other kind of forms of oppression and social determinants of health, and that's not something that I can fix as a physician. And so I think often it feels like, okay, I can give you your methadone, I can give you your Suboxone, I can put you on naltrexone or camprosate or whatever all these medications may be, but I'm not actually able to address the root cause of what's going on. And I think that can often lead, and for me has at times led to a feeling of futility, of sort of, what is the purpose of what I'm providing if I'm not actually addressing the root cause of this?
Mm-hmm.
I think those are sort of some of the big challenges that I see, or that I feel when I'm treating these patients, is, yeah, this fear of our patients dying. I think also, as physicians, we like to see quote unquote success. Like we want to treat our patient with diabetes and have their hemoglobin A1C come down, and that to us signals, we're doing a good job, we're doing the right thing. um, and substance use disorders are just such a challenging and refractory disease that we see a lot of people coming in again and again and again, having relapsed. And I think that based on our kind of physician medical model of what success looks like in medicine, that feels like failure a lot of the time.
Mm. I mean, I can't imagine because I've never experienced it, but I definitely know, even just shadowing from physicians in the hospital, I already sort of feel that, and I can imagine definitely working every day would take a toll, and that's why I want to talk about it, because I think it's so important that we put it out there in the open and we discuss what we can do. Another thing I want to touch on is, stigma is so huge. Societal stigma surrounding substance use disorder is huge. And so from your experience, like, how do you think that stigma itself actually also further exacerbates physician burnout, and even stigma, from society, but also from the medical community?
I would say that the vast majority of clinicians and other providers that I have worked with are incredibly grateful for the services and expertise of addiction physicians. I think, these are patients who can be really challenging to treat, um, because they, require huge doses of medications that people aren't comfortable giving, or, because they do have all of these other social factors going on. And so I would say that for the vast majority of the time, the people, or other clinicians and other physicians, are very, very grateful for our services and very grateful to not have to manage people's active withdrawal or manage their substance use disorders themselves. And so that part can actually be really gratifying and can be a really nice working relationship with our colleagues, in kind of providing care to a patient. Obviously, there's exceptions to that, and I think addiction medicine is, within medicine, probably a slightly newer field, and maybe doesn't always get taken as seriously, or doesn't have the kind of, I guess, validity that some of the more established specialties and subspecialties have. And so I do think that at times it can get seen as kind of a sort of softer type of medicine, or a, more touchy feely, and less sort of academically rigorous. I think the part that I find the hardest, though, is hearing disparaging comments about patients that I work with, whether that's from other healthcare providers, physicians, nurses, other allied health, or from other patients. I actually find that happens quite a lot, where other patients even will make comments about people with substance use disorders or people in society, and it's very discouraging and very disheartening to hear really often kind of dehumanizing and disparaging comments made about patients who are human and are people and deserve the same kind of compassion and care that anyone else does.
Mm-hmm. I'm very curious to know how often do you feel that people don't really understand, as someone who's specialized and who is specializing in this field of medicine, how often do you feel that even other healthcare workers don't really understand the importance of, addictions medicine?
I would certainly say it's the minority of the time. And I imagine that that has probably changed a fair amount, even just within the last few years or
Mhm.
within the last decade or so. I imagine that even 5 or 10 years ago, that may have been quite different. But I would say that for the most part, people are cognizant of how interlinked substance use disorders are with other aspects of health, with mental health, um, and recognize that treating a substance use disorder is a really important part of treating a patient in general. I do think that people can be a little bit at times reductive of, how treatment of substance use disorders works and sort of boil it down to really bare bones or kind of simplistic explanations when we know how incredibly complex substance use disorders are as a disease. But I certainly would say that that is the minority of the time. I think that, yeah, most people now are recognizing how important this is and what a complex disease it is to treat and how necessary it is to treat it. Increasingly recognizing that it is not a moral failing or a behavioral deficit. I think that for the most part, at least, the medical world is recognizing that this is a disease
Mhm.
in its own right, and a disease like other diseases that we treat and not a personality flaw.
Yeah. And so when we're talking about this burnout that, often addictions medicine doctors can face, or other people working, other healthcare workers in this field, how do you think, our medical training can better prepare future physicians, particularly those entering addictions medicine, to cope with the unique stressors of working in populations who have addictions, and especially in terms of the more traumatic experiences, such as those recurrent overdoses or relapses?
Great question. I don't know that I have full answers to this. I think that exposure from early on is really important. I think getting exposure as early as medical school is essential because, all of a sudden on July 1st you become a resident and you have to treat, anyone who comes across your path. And so having already developed some of those skills, to work with this population is really important. So I think integrating it even into kind of pre-clerkship, whether that's, having some shadowing or some formal program of spending a certain amount of time working in an addictions clinic or even a community health center where the majority of patients are disenfranchised or marginalized in some way would be really valuable. I think gaining skills early on to help work with these people, like learning motivational interviewing and things like that from early on, and so that you feel like you have some skills in your tool set to apply when you do work with these patients can be really helpful. Um, and then I also think just having more understanding of oppression and disparities in health, uh, from really the beginning of med school and understanding how that influences health outcomes, because it can be really jarring, I think, to see the first time and to be prepared with that knowledge off the bat is really helpful, as well as I think being equipped with an understanding of the resources available and what you can actually do practically to help these patients. And so having an understanding of how the addiction treatment system works, and what resources are available so that you feel like you have something that you can offer this patient, even if it's small or a brief interaction. But Yeah, I certainly certainly don't have all the answers.
No, yeah, that's great. I think those are all really practical, helpful things for us to, take into consideration. You know, I want to know as well, from your point of view, in terms of self-care practices, wellness practices as a physician, what do you do, or what are your suggestions, sort of, and what is your point of view on the importance of self-care in trying to, minimize burnout and stay healthy?
Yes. I have very mixed feelings. I I think that it is irresponsible to place the onus solely on individuals for self-care, particularly in a field where we are, facing huge systemic issues. And I think that, um, that it's harmful to think that we can self-care our way out of this when it is really structural and systemic issues. And that I think that then leads to a sense that to a lot of people feeling like they have failed for not being resilient enough, when really, we're faced with huge amounts of vicarious trauma, huge amounts of pain of seeing death, suffering, seeing really huge failures in the system to care for the most vulnerable people in society. And so I think that self-care can be used as a bit of a scapegoat for institutions to not take responsibility um, for some of these bigger structural and systemic issues, which do affect us and should affect us. Um, that said, we live in a world where that is the reality. Um, and there is a lot of kind of onus put on individuals to manage their own well-being and be resilient, whether rightly or wrongly. And so I think, while we do live in this system, we have to also be prepared to do that. Sort of within those limitations, I do think that self-care is important and obviously looks really different for different people. I think a big part of it for me is a support network, and that includes both people within medicine and within the addictions field, and people who I can debrief with after difficult cases or difficult scenarios, who are involved and know, can relate to what that experience is and know what it's like to do this kind of work. But equally important, I think, is community outside of medicine. And for me, it's very important for my life outside of medicine to be quite separate from medicine. And have a big part of my life that is entirely unrelated to that, and friends that are unrelated to that, as well as to provide some relief, essentially, from the emotional burden of doing addictions work and working with really marginalized people. And I think that becomes sort of an individual decision of how much you want to engage with that kind of content or that kind of work outside your clinical duties. I actually asked one of my supervisors this recently, because he is someone who does a lot, like spends a lot of his time, I think almost exclusively, doing addictions work. And I asked him, because I didn't understand how you could cope with doing that full time. And he told me that he is very diligent about, when he leaves work, not engaging in anything addictions related. So he doesn't, read books, listen to podcasts, watch documentaries about those topics, because he knows that in that time outside of work is when he needs to recharge, and that taking that content and that emotion into his home life is not healthy or sustainable for him. And so I think that's something that I have been working on this year, because it used to be something that because I'm interested in it, I used to listen to a lot of podcasts and read a lot of books about it and stuff. And so I still do to some extent, but am more mindful about allowing myself some separation from that. And then I think therapy and counseling is important for everyone in the world for different reasons, but I think in this field in particular, to work through kind of the amount of suffering and pain and trauma that we see.
Yeah, thank you so much for that answer. I think that really encompassed a lot of, honestly, really powerful strategies as well, just for anyone who's in medicine. I think that addictions medicine is one of the specialties where that's why this is such an important conversation to me, because it is such a unique, there's, as you said, so much sort of secondary trauma, but I think for anyone listening, those are all really good tips. Just to end off, I mean, this is a bit more of a personal question, and feel free to answer however you'd like, but I just want to know if you would be open to sharing any personal anecdotes or experiences that really sort of highlight the importance of addressing physician burnout, addressing that secondary trauma that addictions medicines specialists face on the day to day.
Definitely a lot of cases. I think one that comes to mind in particular was a patient I worked with last year. And without going into too many details, essentially, this was a patient who needed a transplant, and who, because of their substance use disorder, um, the primary team, the transplant team, was very hesitant to offer this to the patient. And a lot of us on the addiction side of things did a lot of advocating for this patient through, speaking with the providers, going to the transplant rounds, um, you know, writing letters in support, sort of arranging treatment for them afterwards, and really putting these structures in place. And I think it was a case that a lot of us really struggled with when there was not the outcome that we wanted. And I know that that is a case that I and a number of other physicians on the team really took home with us. Um, and I think that a lot of us took really hard, and it was important for us, I think, to all be able to debrief and vent together about it. But certainly, yeah, one that stung.
Mm-hmm. Thank you so much for sharing. It's really good for, us to hear and put some context to some of these really difficult situations that people who are working in this field are put in probably day to day and are dealing with. And yeah, that I think it's really important to, just hear that truth. So thank you. Um, that's really all I have today. I thank you so much for sharing all this information. And I think it's been really great to hear, your perspective and all your knowledge and your expertise that you've gained. And so I guess just to end off, if you were to give one final piece of advice to any medical students, as this podcast is mainly geared towards them, what would be that one piece of advice for us who may be going on to an addictions ward or doing an addictions rotation?
Something that I have spent a lot of time thinking about this year in particular is how we define success. And as physicians, a lot of the time we think of success as being, we've treated this disease, the patient is healthy. And obviously, that should always be the end goal. But the same way that if a patient with hypertension had a blood pressure of 200 over 120, we wouldn't expect within one visit to have them down to a perfect 120 over 80. And I think all of us have the tendency to want to treat things as quickly as possible and as best as possible and get a patient into the best situation possible. And I think that's not always possible within any area of medicine, but particularly within addictions. And so I think I have spent a lot of time this year really feeling like I am failing and not doing enough to help patients because their substance use disorder isn't cured by the time I've finished treating them or by the time they leave hospital. And so I think for me, it has been a lot about shifting the goalposts of what I define as success. And sometimes that doesn't even mean getting them on medication. Sometimes that just means getting them a naloxone kit or providing them with outpatient resources or having an interaction where they feel safe and not judged and feel, more capable of bringing this up again in the future and addressing it, with another provider or at another appointment in the future. Which is not to say that, we should lower our standards for treatment. Obviously, our end goal for all of these people should still be to help them survive, to help them thrive, to help them live the best life that they want to, and get them into treatment where we can provide harm reduction when treatment isn't their goal. But that within each kind of encounter, I have needed to redefine what success looks like. And so I think that is something that I would share with and recommend to people is think about what success looks like, and that it may not be what you ultimately want it to be, but that doesn't mean that you haven't made progress. I think the one other thing I would say, unrelated, is that for me at least, I know that I am not going to be able to do addictions full time. And that I need to balance it with other works. I'm going to be doing my practice is going to be a mix of general internal medicine and addictions, because I know that that's what I need for this career to be sustainable. And so particularly if your job is heavy or some aspect of it is particularly emotionally draining, to find ways to balance that, whether that's, different settings, inpatient versus outpatient, or combining kind of areas of practice, that for me at least, and I think for a lot of people, is an important part of creating a career that is sustainable.
Yeah. Thank you. Those are all, again, really great lessons, I think, for everyone to hear, and all very relevant to the real world and real medicine and how we practice. So thank you so much. Do you have anything else you want to add?
No, I don't think so. Do
Okay,
addictions medicine. It's great. It can be
awesome.
really sad, but it can be so, so rewarding when it goes well.
Yeah, no, for
And
sure.
we need more addictions doctors.
Okay. Thank you so much. And then we'll end it there.
Okay. Thanks so much.
Thanks for tuning in to Just Medicine.